The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I'm Tony Urbanic, and we are gathered here for the next episode of TMD Demystified. Today's topic and today's title is TMJ is not a dirty word. TMJ is not a dirty word. TMJ should not be a dirty word. TMD should not be spoken of disparagingly. Today, I'm going to kind of pull all of this concept together in one place. I've touched on it multiple other places and other episodes, but today I just want to make this point because it is thought of disparagingly. The whole concept, the disease, the misunderstanding, the unknown, and all of it is just truly false. It just doesn't stand reason and doesn't stand examination of the facts. So we're going to take the next 20 or 30 minutes, probably won't drag it on that long, but to go through this step by step and to describe what actually the facts are, how it works, how you need to actually look at this and put aside all of these fixed ideas that are out there about this problem and about the disease itself, about how to fix it, about the patients. So, and we know that it is thought disparagingly. I know it's thought disparagingly for multiple reasons. I think in my universe, the biggest reason is that you can hardly find an oral and maxillofacial surgeon, which is my specialty, who wants anything to do with TMD, TMJ anymore, only when they absolutely have to, and they're faced with a patient in their office, and then the question is, what do you do with these folks? There are still a few oral and maxillofacial surgeons who want to do total joints. That is a really complicated and mostly unnecessary now procedure, which we can show, which we can prove by facts. But I don't want to go too deep into that particular issue today. And the same thing goes for the general dentist, only more so, because especially, all of the general dental community, both young and old, the young folks coming out of school have no specific training about this problem, or little to none, and the established doctors already know all of the disparaging things that they think are going on about the disease. It's a no-win situation for the disease process, for the patients, for the doctors, for the whole concept. And TMJ is thought of in the dental profession as a, quote, dirty word. Don't want anything to do with it. Don't say it. Don't want to hear about it. Don't speak it. I'd rather do my usual and customary treatment plan, which doesn't have anything to do with TMJ. All right, so that's just a preliminary preface to what I have to say. So it's a misunderstood problem, and it doesn't have to be a misunderstood problem. It's a misunderstood diagnosis. I just finished up the last episode on the misdiagnosis of TMD, and that TMD itself does not constitute anything that replicates another disease. It actually is a disease unto its own. And when you understand it, it's perfectly simple. It's not complicated. But everyone thinks it's a complicated, difficult problem from the beginning, from when you're first introduced to the concept of TMJ, TMD in dental school, because it is perpetrated as a very complicated joint, first of all. The dental establishment and the dental professors always and have always spoken of the TMJ anatomy as a very complicated anatomy and a very complicated joint, which is not true. I won't go through many of the details. It is similar to any other joint in the body. It has a meniscus. The anatomy itself is a little unique in that it has a rotation and a translation out of the glenoid fossa also. But that's not a major issue. But the operation of this joint, physiologically, anatomically, the synovial fluid, the meniscus, the histology, the neuroanatomy of the TMJ is similar, almost identical to the anatomy physiology of a knee or a hip or an elbow. It's innervated with the same nerve endings. It's innervated with the same complement of nerves in the autonomic nervous system. It's a joint like any other joint. So, the concept is it's very unique. It's told to us that it's very different, and it's just not true. The next point, and I already touched on, is there's no solution, and that is by experience. Whether the patient comes into the general dental office or oral surgery office. I certainly had my experience with well over 2,000 patients, because I did 2,000 temporomandibular joint surgeries between, let's give you the years, between 1976 and the year, let's say probably ended right around 2013. I did my last temporomandibular joint surgery, half of them through an arthroscope, half of them open joint surgery. And I finally gave up. I finally said, these results are not good enough. I just can't do this anymore. I can't, do this and with a straight face and tell patients that I have a solution, because a good number of those patients would be back in my office. And that was my experience. That is the experience that had been shared with me by every general dentist. 50% of dentists, and this is my evaluation of the general dentistry out there, but after talking to hundreds and hundreds of dentists in Middle Tennessee, half the dentists don't want anything to do with TMJ. If you say TMJ, they just close their mind, close their ears. I really don't want to hear about it. And half the dentists who are forced or want to see these patients in one way or another give the patient a night guard and tell them this is their treatment. And then, of course, there are a few gurus out there who I'll discuss a little bit later on, gurus for TMJ surgery. But one of my very good friends and colleagues, who's actually an orthodontist and placed very highly in the orthodontic industry as a very well-known, well-established orthodontist, he likes to tell me the story that his mentor in his orthodontic training told him the best way to treat a TMJ patient is to refer it out. And that's the consensus. And we all know that. I'm not telling you anything you don't know. And it's not necessary. It's not true. Everyone thinks that there's no solution, so why should I get involved? Next is the difficult patient. Besides the fact that there's no conceived or considered solution to the problem, everyone thinks, everyone is a little exaggeration. There are people that will disagree with what I have to say, but the majority of practitioners in the dental professions think that these patients are crazy. They're difficult to deal with, which is absolutely not true. I've stated very, very many times before, and it has been my definite experience that these patients are no different than the bell curve of any patient that walks into your office. There are different personalities. There are different problems that the patients bring in under that bell curve, but the majority of patients who come in with the symptoms of TMD, diagnosed or undiagnosed, are just regular old patients. What the problem is that they have been abused by the system, and they have been misdiagnosed or not treated or told there's nothing that can be done, and go from doctor to doctor to doctor trying to find out someone who understands the problem or possibility that someone might have a solution to these terrible symptoms that get worse and worse over the years. So they're not crazy. They're just crazy with pain. They're crazy with frustration. I see it on a daily basis, on a weekly basis. And, if I have the empathy for these patients, I've said many times before, it's not an unusual experience for me to be in the middle of a consult and just explaining to the patient what the symptoms are, going through a symptom list, and the patient in their mind or verbally checking off each one of those symptoms, and just the tears, they start to cry because they realize someone at least understands the problem. I haven't even talked about the solution yet. And I've seen it so many times, and I have the Kleenex ready, and I just sit there and listen, and I let them go through that a little bit, and then we get on with the consultation. But they're not crazy. These people are not crazy. They're terribly frustrated, terribly frustrated. The next is that the patients, everyone thinks that if there is a treatment, they're very complicated treatments, which again is not true. Now, there's definitely complicated treatments out, and that brings me to the concept of what I call the gurus. And I don't want to beat a dead horse, and I don't want to, invalidate my colleagues who are on that train, but to do a consultation that lasts hours. I mean, I've heard someone here locally does a 4-hour consultation on temporomandibular joints, or the symptoms of what patients have a temporomandibular joint problem. I think that's the most I've ever heard, but I've heard that from a couple patients, I think 3 in particular, about these long with one of my colleagues here in Middle Tennessee, who tries to treat TMD and makes it complicated with 4-hour consultations and a review, a written diagnosis and check boxes that go on for pages and pages and pages and pages. The most egregious record of a consultation I've ever seen ran 30 pages, and it came from, I remember very well, it came from Wisconsin. A patient actually traveled from Wisconsin to see me and brought her record of her initial consultation. That's a complicated consultation, and the treatments get even more complicated. That can go on for years. Again, I'm not going to go through the details, but we have that concept being done here in Middle Tennessee where you have to rearrange the entire occlusion, either orthodontically or operatively, to every crown and every tooth in the mouth. That can go on for years, and it can go on for thousands and thousands and thousands of dollars. No wonder TMD has a bad reputation, and it is thought to be a dirty word. The next is and it kind of ties to the gurus, because I see it, and I'll call it like it is, doctors gaming the insurance company system by putting together a series of examinations and a series of x-rays and a series of treatments that go on and on. And to me, and I'll take total responsibility for what I say, and I will say it, that it's gaming, trying to game the insurance companies, and the insurance companies are not stupid. And that is why the insurance companies don't want, if at all possible, want anything to do, both dental and medical, in covering TMJ, TMD. And this is getting worse and worse over time. Of course, the insurance companies are tightening down, as you well know. If you are involved with insurance in the dental industry, and almost probably 98% of you are, you know what I'm talking about. Insurance companies are doing everything they can to tighten down on the doctors, on the providers, and cover as little as possible, with as much copay as possible, with as much documentation as possible. And in the end, most often when it comes to TMJ, TMD, they still don't want anything to do with it, or limit it so severely that you can't really do a reasonable treatment plan of any kind, both certainly surgical and non-surgical. I can talk about the whole hour talking about the blowback that I received from insurance companies trying to do temporandibular joint surgery. That was always covered under medical insurance, and it was a fight from beginning to end. And it included each and every insurance company when it came to them wanting to cover any kind of surgical treatment for the temporandibular joint. So gaming the insurance companies has created a lot of blowback from insurance companies, as you would expect, shouldn't be surprised. And I won't say anything more about that. I mean, insurance has some value to it in some cases, but they want to avoid coverage if at all possible. So the patients are extremely frustrated. They're extremely frustrated going from doctor to doctor. The greatest number of doctors that a patient has told me that they have seen over a period of time, in which was 20 years, and I had a patient who swore to me that over 20 years, she had seen 150 doctors trying to help her explain to her, give her some assistance with all these painful symptoms and various symptoms around the jaw and around the neck that were obvious when she saw me was TMD. And that was the record. And she claimed she could prove it. I still question that, but it is routine for me to ask, how many doctors have you seen for your symptoms over a period of time, whether it be 5 years or 40 years? And the number ranges between 5 and 10, sometimes 15. Again, if they had a solution, they wouldn't be seeing the rotation of all these doctors. And the doctors are certainly frustrated, and admittedly so, because they have been misguided as to exactly how to treat this problem, because the understanding of the pathology, the pathophysiology of the problem has not been addressed. It just hasn't been addressed. I guess that opens up my remark about, well, what is the proper way to address that? And it's quite simple. It's all about inflammation in the joint. And if anyone else out there listening to me can figure out a better way to decrease inflammation in the temporandibular joint over the long term, then I'm willing to listen, and I'd support you if you come up with a better way than just unloading the joint with a proper device which unloads the temporandibular joint, and a protocol that you can use safely to do it over an indefinite period of time, basically the lifetime of a patient. And if you unload a temporandibular joint long enough, it doesn't take long for the inflammation to decrease. And when the inflammation to decrease, all the symptoms decrease and go away. And that includes the entire symptom complex of headache, earache, jaw pain and neck pain, tinnitus, subjective hearing loss, and vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking. Includes them all. And all of those, the pathophysiology is well covered in other episodes in this podcast. And I'd recommend you go back and look at the titles. And if you're interested in the details, you have several options. You can read those particular episodes, or you can get in touch with me or my company or my director of marketing and education, Dr. Naomi Engelman. And she is a doctor of education, and she'll be happy to educate you. And I think that the doctors are just as frustrated, if not more frustrated. And when I say doctors, I just don't mean dentists. The physicians, if they just think that this might be TMJ, they want to refer it elsewhere. They don't want anything to do with it. They know they don't have the answer. They don't want to get involved. They don't want to even learn other than how to properly diagnose and send it elsewhere. They want it sent elsewhere. That's the physician's standpoint. And there's a lot of education that needs to go to and toward the physician profession and associated physician's assistants and nurse practitioners who are well open to listen. Nurse practitioners and physician's assistants know they don't know, and they are well ready to listen and be educated regarding TMD. Doctors are a little harder to get to, first of all, to get access to, and they have fixed ideas. But the dental profession has too many fixed ideas about this problem. The patients are crazy, the treatments are complicated, there is no solution, the joint is special, it's a special joint, that's why nobody could figure it out. Absolutely not true, not factual at all. It's all about the inflammation. If you unload the joint, the inflammation goes away. And the pathophysiology is well explained on multiple other episodes in this podcast. So the symptoms themselves, if you suffer from this problem, are never ending. And they cycle. They go from up and down, because that's the nature of inflammation. Inflammation is not like this. Inflammation is like this in the early stages, and only in the latter stages is that inflammation to the point where it just gives constant pain, constant symptoms, rather than the cycling. So it's important to learn about the simplicity of the pathogenesis of this problem. And that's really what I figured out, which is I didn't invent anything. I just figured out how to connect the dots, and why. What I figured out was anatomically, physiologically, how and why inflammation within the temporomandibular joint, within the capsule itself, beginning with the meniscus, which is the first tissue to break down. The meniscus is the first tissue to break down, creating chronic inflammation. And then how chronic inflammation within the joint cascades anatomically, neurologically, biochemically into directly causing each and every one of those symptoms. And if you make the inflammation go away by unloading the joint, like a set of crutches would unload a bad knee, the inflammation will decrease, and the patient has long-standing relief as long as they use an appropriate protocol. And that's part of the education to the patient. So learning the simplicity of treatment is paramount, extremely important. And that's what I claim, and that's what we can prove. And our academic study can prove it from an independent university here in Middle Tennessee State University, based on our, at that time, 3,000 successful cases treating this problem. So you will, instead of thinking and feeling that TMJ, TMD is a dirty word, you will feel good when you know you can actually do the solution. And that's why doctors who follow suit with what we show you, what we teach, using a simple device that patients can use at the beginning 24/7. They can speak with it. They just can't chew with it in their mouth. They can speak. They can drink with it in their mouth. It's easy to use. It unloads the temporomandibular joint by disoccluding the posterior teeth according to a careful and appropriate protocol, followed by nighttime. And if the patient can follow the protocol and the doctor teaches the appropriate protocol, and you use the device correctly because it's just a tool, you'll feel very good. You'll change your fixed ideas about TMD, and TMD will no longer be a dirty word, because it's not. It shouldn't be. You should make it an easy part of your practice to treat these patients. It's not complicated. It doesn't take a whole lot of time. It takes a little knowledge and reaffirmation of information you already studied. I know you studied this information in the basic science in dental school, just like I did. And all the information is there. There's nothing there that hasn't been there for 50 and 60 years since Dr. Costin in 1936 wrote his initial article about temporomandibular joint disease, better known as Costin syndrome, going back to 1936. And actually, that's not a whole long time ago. That was less than 100 years, doing my math, about 87 years ago, when it was first entered the mindset of any practitioner. And Dr. Costin was an ENT. So think about that. Think about how you can change the course of events for the thousands of patients in your community, millions of patients throughout the United States. 45% of females have temporomandibular joint symptoms. Most of those symptoms have been misdiagnosed. You know, the literature states, and it varies all over the board, but if you read the studies on TMJ, TMD, the incidence, prevalence of TMJ varies between 15% and 30% of the female population, because it is heavily weighted to the female population, but actually it's much more than that, because those studies discount the majority of symptoms that the patients have that have been misdiagnosed by others. So they really relate to jaw symptoms, ear symptoms, and don't include the well-known, well-established, well-documented symptoms of Meniere's disease, tinnitus, subjective hearing loss and vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness. The patients who have those symptoms, which are totally misdiagnosed and should be added to the prevalence and incidence of patients with TMD. So it really is much higher. And I quote about 45% because that's the percentage that I've seen over the years, that when you study the population at large, patients that answer, oh yeah, I have these symptoms, 45% of females raise their hand. All right, enough for today. I appreciate your interest. If you'd like to learn more about the Urbanic device and protocol, how to use it successfully, it's quite simple. You need a little knowledge. We have an online course that provides you with now CE credit. You can learn more about what we do, who we are at www.urbanictmj.com. We rebranded recently, and the website has changed slightly. So it's www.urbanictmj.com to learn more about our device, our protocol, our company. You can also talk to me, email me at tony@tmjservices.net, or email Dr. Naomi Engelman at naomi@tmjservices.net. We'll be happy to give you more information. We can set you up on the course. We can get you involved easily with treating your patients, as easily as we do here in Nashville, and develop a very significant practice in this if you wish. So for today, I look forward to the next time we can speak, which will be in a week. And I will select a topic of interest, and hopefully you'll be interested in hearing about it. I am Tony Urbanic, and this is TMD Demystified. Thank you so much.